Hey, good afternoon and good morning to some of you. Thank you for joining today's National Office Hour, Planning for the PCA Supplemental Activities, Intimate Partner Violence. My name is Jennifer Nolte, and I serve as the National Association of Community Health Centers Director of Primary Care Associations and Health Center Controlled Network Relations Team. This National Office Hour is intended to provide a centralized, coordinated space for PCA staff to interact with the Bureau of Primary Healthcare and subject matter experts from health partners on intimate partner violence and exploitation, a national training and technical assistance partner, or NTTAP, and Futures Without Violence on the deployment of supplemental training and technical assistance to state and region-specific health centers regarding intimate partner violence. This office hour will provide a venue for resources and ideas discussion. Next slide. The learning objectives for today's National Office Hour are to, number one, gain clarity on the BPHC expectations for use of the supplemental award. Number two, discuss strategies and approaches for the PCA supplemental award execution. And number three, understand intimate partner violence, training and technical assistance resources that are available for free to the PCAs. Next slide. After I finish my welcome and housekeeping portion, we will be joined by the Bureau of Primary Healthcare's Folashade Osibanjo-Quinn, the NTTAP Project Officer, and Sean Chapman and Bryant Goodine of Strategic Partnerships Division in the Office of Quality Improvement to provide BPHC context, including the award rationale and expectations. We will then have Anna Marjavi, Director of Futures Without Violence, and Erica Monasterio, who serves as a consultant to share existing intimate partner violence training and technical assistance resources. There will be time for questions and discussions, so please feel free to add these into the chat. Next slide. Just a few housekeeping items. We want to make sure that your microphone remains muted when you're not speaking to avoid any disruptions. We want you to direct your questions or comments through the chat box that's located at the bottom of your Zoom screen. So then we will address them either during the presentation or in the Q&A segment of the session. Again, this is specifically in the chat box. Raise your hand feature if you wish to contribute verbally. We will also allow that to happen. This session is being recorded, so the recording will be made available to participants following today's session. The resources and materials that are pertaining to this session will be shared and available throughout the session. And again, we do honor your feedback, and we want to make sure that you complete the evaluation following this session. We will have a link in the chat, and then we will also follow up with an email that will also have the link for that evaluation. Next slide, please. At this time, I will turn it over to Sean from the Bureau of Primary Healthcare.
All right, thank you, Jen. And good afternoon, and I guess good morning to those on the West Coast. Again, my name is Commander Sean Chapman, and I'm one of the Deputy Directors in the Bureau of Primary Healthcare Strategic Partnership Division. So I'm here with two of my colleagues, Sade and Bryant, who represent our National Partnerships and Primary Care Association teams respectfully. So we're going to take a few moments to provide some important context and reminders related to the IPV supplemental funding that was recently issued. So first and foremost, huge thanks to the NAC team for organizing this meeting and providing the platform for us to touch base. So again, we're going to take a step back for context. So some of this you may already know, but it's important to ensure that we're all in the same accord. As the old saying goes, you don't know where you're going until you know where you've been. I'm pretty sure I butchered that, but you get the point. So as many of you know, combating intimate partner violence has been a department-wide priority for some time. So Congress approved this money for HRSA every year for the past 6 years or so. Again, this has been an agency-wide initiative, so several bureaus and/or offices across HRSA have been addressing IPV. So initially, HRSA split the money between the Office of Women's Health and the Bureau of Primary Healthcare. The funds that we received in the Bureau were used to support the IPV NTTAP, Futures Without Violence, who you'll be hearing from shortly. Now, this was done to really shore up research and training and technical assistance and expertise at the national level. So since that initial funding, Futures has proven time and time again to be a very impactful partner. So next step, after years of that foundational TA support at the national level, we recognize that health centers will also benefit from implementation at the state level, to really increase or deepen the impact of the IPV funding. So again, we started at the national level with our NTTAP. And again, the next logical step will be to implement IPV TA support through the state PCAs, considering that you all have a very special vantage point and can really meet health centers where they are within their communities. So that's only part of how we got here. Now, in terms of timing, well, you all have been working with the federal government long enough to know that sometimes it takes a while for decisions to be made and for bureaucracy to really move. And when it does happen, timing can be less than ideal. Be that as it may, please know that we will always communicate any new information as early as possible. That is as early as possible within the parameters of federal guidelines and processes. So again, as my one ask is for you to continue to communicate any issues or concerns with your strategic partnerships advisor, previously known as project officer. Your SPI is essentially your first and primary point of contact for any matters concerning your PCA program, including matters related to this funding. Just like with any partnership, is maintained through constant bi-directional communication, understanding, and flexibility. So each one of our staff members are dedicated to fostering and maintaining that partnership, so continue to reach out to your SPA with any concerns. So with that, I'm going to pass it to Sade to provide a little bit more information in terms of overall context. Sade?
Thank you, everyone, for having us on the call today. As Sean mentioned, my name is Folashade Osibanjo-Quinn. I am the project officer for IPV and Human Trafficking NTTAP, Help Partners on IPV and Exploitation, also known as Futures Without Violence. In 2017, HRSA developed its initial agency-wide strategy, which was the 2017-2020 strategy to address intimate partner violence. This is what Sean referenced as the agency-wide approach to addressing IPV. And the goal of this strategy at the time was to respond effectively across the agency to addressing IPV in all of HRSA's supported settings. And at the time, the Bureau of Primary Healthcare supported this inaugural 2017-2020 HRSA strategy in collaboration with the Office of Women's Health, as well as the Administration for Children and Families. In addition to the strategy, some of the other initiatives that we've taken on within the agency and specifically within BPIC to support the IPV effort at the HRSA level are two demonstration projects that you might hear Anna reference later on in her portion of the presentation. We have Project Catalyst as well as the Survivor Health Connection Project. And both of these projects were successful in increasing health center staff's awareness of IPV within their patient population. And they proved so effective that the Bureau of Primary Healthcare established the new IPV NTTAP, Futures Without Violence, Health Partners on IPV and Exploitation, to be our 21st NTTAP and to provide technical assistance to HRSA's health centers. Since then, there has been a new, we call it a strategy 2.0, a 2023-2025 strategy that builds on that earlier strategy and encourages us to continue our efforts in terms of identifying partnerships, addressing barriers, and strengthening existing programs while creating new activities to prevent and respond to IPV. Can you move to the next slide, please? The strategy consists of 3 aims, each describing how HRSA bureaus and offices can prevent and address IPV. And to achieve all of these aims outlined in the HRSA IPV strategy, we think it's very critical that we have Futures, our IPVL partner, as well as the health centers, working with the Primary Care Association. So first and foremost, we think the PCAs can play a role in informing how we focus our efforts within HRSA and how our IPV NTTAP works with the health centers. Because we believe you have a very unique perspective to be able to share with both Futures as well as the health centers in your states. PCAs have a great understanding of the needs of the health centers in their states and regions and can connect them to training and technical assistance that HRSA offers at the national level. PCAs can also help strengthen the infrastructure at the health center level by encouraging health centers to partner with domestic violence programs. PCAs can support training to health center workforce in their ability to be able to prevent and respond to IPV. PCAs also can help promote, address attitudes around IPV, but also share evidence-based interventions, which I know Anna is going to talk about specifically within the portion of her presentations. So we see the PCAs really playing a very key role in the implementation and in support of the larger HRSA strategy. Next slide, please. In addition to the HRSA-wide strategy, there is a 2023-2025 implementation framework that provides HRSA-supported settings of care with actionable steps to prevent and respond to IPV. The steps in these documents aligns with the 3 aims that I mentioned in the previous slide. Next slide, please. And what you should see here are 5 building blocks that are part of the framework that are meant to enhance your organization's capacity to prevent and respond to IPV. And they include suggested activities to help establish or strengthen wherever you might be in terms of your level of implementation. So we may have some organizations that are very much at the start of their work around IPV, and so they're suggested or examples of initiatives that you can undertake at that level. And then if you are at more of at an advanced level in terms of your implementation, there are also examples of additional activities that you can sort of take to go to the next steps in terms of implementation. This framework is not meant to be a prescriptive document. Instead, it is intended to provide you with implementation tips as well as examples that can help you bridge the gap between the federal activities like the strategy, as well as actions that you as Primary Care Association can take at the state, regional, and local level. And I'll make sure to provide the links to both the strategy and the framework in the chat if you would like to access and download. And now I'll pass it to Brian.
Thank you, Sade. My name is Brian Godine. I'm one of the strategic partnership advisors working within BPIC. And I wanted to go over just a couple of key points. One, with this new added objective, IPV, it raised the number from 12 to 13. We are requiring that PCAs provide us with 2 tasks, but we understand and we appreciate that we've given the PCAs flexibility to partner with your strategic partnership advisor to determine what those 2 tasks are. As Sade said, we know that you have a fundamental knowledge of what is going on within your state. You know where they are in terms of their understanding of intimate partner violence. And we trust that what 2 tasks that you provide will factor that in. As Sade said, you should have received already the 2 resources, the Intimate Partner Violence and Sexual Violence Victimization Assessment Instrument for use in healthcare settings from CDC, and then also the Preventing and Responding to Intimate Partner Violence and Implementation Framework from HRSA. You should have received those from your strategic partnership advisor. If you have not, if you send them an email, they will send that to you post haste. And I would like to now pass it on to Anna with Futures Without Violence.
Thank you so much. Thank you, Sean. Thank you, Sade. And also thank you, Jennifer at the top. I'm Anna Marjavi. I direct Health Partners on IPV and Exploitation, which is a project of Futures Without Violence. We're funded by HRSA's Bureau of Primary Health Care to work with health center staff to support those at risk of experiencing or surviving intimate partner violence, human trafficking, or exploitation, and to bolster prevention efforts. And we do that in a number of ways, all of which are free. All of our TTA is free. We offer learning collaboratives on key topics for small cohorts. We have webinars in English and Spanish and with ASL interpretation, and those are all archived on our website. And then we also have clinical and patient tools, an online toolkit, evaluation tools, health IT tools. And so I'm going to lift up some of these resources for you today. We have a website, healthpartnersipve.org, and an online toolkit, ipvhealthpartners.org. And you see on the screen my colleague, Erica Monasterio, who will introduce herself in just a moment as well. Next slide, please. So Project Catalyst was a tested model of leadership teams. This was an interagency project funded both by HRSA's Office on Women's Health and Bureau of Primary Health Care, as well as ACF's Family Violence Prevention and Services Bureau. And it fostered leadership and collaboration at the state and territory level to improve health and safety outcomes for survivors of IPV and human trafficking in health centers that were partnering with local domestic violence programs, working both to support the interventions, the clinical interventions, as well as promoting prevention. And those leadership teams consisted of 3 partners from the state or territory's primary care association, Department of Health or Public Health, and Domestic Violence Coalition. And there were 3 goals. One was to look at the state opportunities in terms of policy opportunities, both within other initiatives like SDOH or maternal health initiatives, where we could infuse and really bring over responses to IPV and trafficking. Also, we wanted to build practice transformation and partnering domestic violence programs and health centers and really promote the way that they were providing bidirectional referrals to each other, which we'll talk more about. And finally, statewide spread and TTA engagement. So it was through these leadership teams that they provided TTA directly to their sites, both at annual meetings and other convenings where they brought their sites together. And it was very impactful, which is why I'm really excited to see this funding now for UPCAs to continue on this work, because we really found it effective and very meaningful in terms of spread and engagement across your states and territories. Next slide, please. So these logos represent the 30 state and territory primary care associations, domestic violence state coalitions, and public health departments that took part in Catalyst between 2017 and 2021. And just to note that many of the PCAs and state domestic violence coalitions did not actually know each other before this project. So for many, it was the first time they were connecting. I'm going to encourage all of you on the line today to think about reaching out to your state domestic violence coalition, getting to know each other and recognizing how many overlapping goals you have around health and safety. And we'll talk more about those opportunities. Next slide, please. So really the heart of our model and all of the work that we do as an NTTAP and with Project Catalyst was building these kinds of meaningful partnerships between health centers and community-based domestic violence or human trafficking programs. And we're thinking both about staff and about patients as we do this work. We know that staff and patients or clients need this kind of access. So for example, many staff of domestic violence programs may not have a medical home or even medical benefits. And so a community health center is a really great offering for them, as well as for their clients who come in many times with primary care needs or sometimes acute health needs who need that referral over to a health center. Similarly, as we're all working at community health centers and you're initiating conversations with your patients about IPV, some of them are going to need these referrals to domestic violence programs. And by sharing a little bit about what an advocate offers, what the services look like, what is a 24/7 hotline, you're going to really increase access to those safety supports. Next slide, please. So some of the other benefits of these partnerships include safety support for staff and patients that I mentioned, and safety planning. Also help for clients to establish a primary care provider and moving away from emergency level care, which many folks are accessing because they don't have a medical home and are not enrolled in healthcare. So we can really facilitate this health enrollment for survivors, clients, and for staff. One unique thing is that survivors of domestic violence can enroll in healthcare year-round. Experiencing IPV is considered a qualifying life event where they can enroll year-round. So we've developed a couple of tools specifically on this health center enrollment, and you'll see the links on these slides. And I'm also going to put in the chat a resource list with a lot of these links so that you can easily access these tools that I'm mentioning. We also have some key partnership resources that outline some of these benefits and opportunities to connect with your local programs. Next slide, please. So one thing I want to let you know that's really exciting is that state coalitions have ARP funding to focus on health access. So I know many of you on the line also had ARP funds that are now expired. However, the state coalitions have these ARP funds until September of next year. So they're starting to spend down and really think about how they're going to put those funds in place to increase health access for survivors of violence at local programs. So domestic violence serve as statewide and territory-wide leaders in the efforts to end domestic violence. They connect to local domestic violence programs similar to the way you all operate. They have member programs all across their states, and they're valuable resources for information about their services, their programs, legislation, and policies that support survivors. There's also 19 tribal coalitions, and so we have a link here on the slide for you to identify your state, territory, or tribal coalitions. And as I mentioned, just know that there's was $1 billion in funds that reach domestic violence programs within tribes, cities, states, territories. So it's a really unique opportunity to think together about the opportunities to partner up and reach your member programs together and possibly even connect them up intentionally, bring them together and let them know what each other is working on and provides, because even the local programs don't always know each other. So it's a great opportunity to make those connections. And I'm going to pass it over to Erica, who will introduce herself and tell you a little bit more about the health impact and our evidence-based cues intervention.
Hi, I'm Erica Monasterio. I'm a family nurse practitioner and have been a consultant for training and technical assistance with Futures for over a decade. So I'm going to talk a little bit about first the rationale and then some approaches to implementation of these new directives. So as a primary care provider, I am always very interested in the rationale, the why. We have a lot of different directives and advisories and things that we need to focus on. And so understanding why it's important is really an important motivator for those of us in the exam room. So you can see on this slide about health impacts, at the top of the slide is a word cloud that was made directly from findings posted by the CDC, a summary of research done in the area. So in addition to what you might assume around perhaps the physical damage that occurs with sexual assault, rape, or abuse, and the trauma, excuse me, I have a fly in here, the trauma that results from that situation and the overwhelming behavioral health issues that may emerge. There are also very significant chronic health problems associated with domestic violence, intimate partner violence, and human trafficking. So in this word cloud, as you can see, there are things like stroke. And I'll just say, in talking about the research, much of this research has been done with women, much less research with non-binary people, with trans people, with men. So when we talk about the research, we're also often talking about the impact on women, and that's just the state of the research. So there has been research finding that women who experience domestic violence are 80% more likely to have a stroke, 70% more likely to have heart disease, 60% more likely to have asthma, and 70% more likely to drink heavily than women who have not experienced intimate partner violence. So certainly being aware of this background, whether it's something that has happened to the individual in the past, is happening in the present, or also providing preventative education to help individuals identify when they're in a relationship that might lead to these kinds of interactions or has warning signs of these kinds of interactions, and identify that early and maybe make different choices about their engagement in those relationships. We have the opportunity to intervene here. Now, there are lots of barriers for equity in care. We may not be presenting our questions or interacting with our clients in a way that's culturally responsive. We may not be linked to support services that are appropriate for the individual or the population that we are seeing. There's an overall lack of access to housing, health services, and jobs, et cetera, which makes it difficult for individuals to prioritize issues, particularly painful and conflictual issues like intimate partner violence. There's often a lack of trust in official systems. We know that with the best intentions, we don't always provide the best, most sensitive, or most culturally appropriate services. Certainly language barriers get in the way. And there's a lack of safe options in terms of reporting violence, a fear of the police, a fear of court involvement, and a deep fear of family disruption or loss of children related to any interaction about the nature of a violent relationship. And of course, marginalized communities are more vulnerable to these barriers than the rest of the population. Next slide, please. So we often find mandates, and when we use electronic health records, we may even be pushed into or directed towards screening, screening questions, screening approaches that have been found to be valid and sensitive. And however, Futures Without Violence doesn't really promote screening. We really promote a different approach. So why is that? Well, screening has been found repeatedly in the literature to result in low disclosure rates. It may not, the questions may not hit right on what that individual is experiencing. The environment in which the questions are asked may not really promote disclosure or any kind of real connection. The audience in the room, if you're not alone, may not make it safe to talk about the issues or advisable because maybe your children are in the room. Screening is not really survivor-centered, and it's absolutely disclosure-based. So if you say, yes, this is happening to me, then you get resources, you get information, you get support. If you say nothing or say no, then you get nothing. And it's really a missed opportunity for prevention education, which is such an important aspect of all the work we do in healthcare. You know, you want to start as far upstream as you can, and prevention is far upstream. So what we're looking at and what we've looked at in our work at Futures is, what if we switch the script? What if disclosure or identification of those patients or clients who are experiencing intimate partner violence or human trafficking were not the goal? Can I have the next slide, please? So we know from the research that the use of a structured screening tool at enrollment does not promote disclosure. It doesn't promote any in-depth exploration of women's experiences of abuse. And again, the research reflects women, so the language here reflects women. And we also know from the research that women, and this was from very large subject pools, that women are more likely to discuss experiences of violence when nurses or whatever provider, in this research study was nurses, initiated open-ended discussions focused on parenting, safety, and healthy relationships. So screening is an approach that really hasn't been found to be the most effective approach. Yes, it's fast. Yes, you can hit the little check boxes. Yes, you can move to the next screen if it's something that's required on intake, but it really doesn't promote communication or open discussion or any kind of help seeking. Can I see the next slide? So what we advocate in the work we do with Futures is an approach that we call cues for the initials, a nice little mnemonic. We're such fans of mnemonics in primary care, to help us remember the steps that we can take to engage with our clients about issues of relationship quality. So cues is an evidence-based intervention. There has been a fair amount of research now looking at the impact. And I'm just going to quickly go through what CUES stands for. Now you can see over on the right-hand side these little images of cards. And here is I don't know if you can see this against the background. Here is a card. There you go, maybe. And these cards are really tools for us as providers. For our clients, it's something they can take home. You can see it's small, it's easily hidden if it needs to be. And it opens up with a whole lot of information. And I'm sorry you can't really see it here, but you can certainly see it in the PDFs that Futures have on their sites for clients so that they can take steps regardless of whether they disclose to you in the exam room. So we advocate using these cards and sharing these cards and going through these steps. So the first step is the C for confidentiality. And it's just essential, no matter what the environment in which you're seeing clients is, that you see the patient or client alone for at least part of every visit, and that you discuss and disclose the limits of confidentiality. So this is going to look different if you have an individual who's under 18 than an individual who's over 18. Because of reporting requirements in different states, but to ask an individual in front of their partner or children what's going on in their most intimate of relationships or what's going on in the most painful aspect of their life is not fair to the client and certainly does not engender any kind of discussion. The UE is for universal education and empowerment. So we want to normalize the activity, and that's not normalize violence or abuse in a relationship, but normalize a conversation about how are things going in your relationship? How are you feeling? What are some good things about your relationship? What are some things that you'd like to change? So making it a normal part of a healthcare conversation. And I often open this with, relationships are so important in our lives. So as I'm getting to know you, I'd like to get to know a little bit about how you feel in your relationships. And then you want to make the connection. So making the connection is that really our relationships have a huge impact on our health. And then, in the steps that we train people in using this approach, you open up the card, you kind of give them a guided tour to the card, you give the client a card to look at themselves. And the card, some of the unique things about these cards are that, first of all, they start with positive aspects of relationships. So what are signs of healthy relationships? And then go on to help identify signs of more problematic relationships, ways that individuals use to cope, some key steps you can take around enhancing your safety. And probably most importantly, on the back of every card are national resources, and different PCAs or clinics can add their own state and local resources to the backs of the cards. So, and then finally, the S is for support, probably the most important part, which is that you want to have an empathic response. You want to connect with your client. And when there's and you want to really reinforce great things that are going on in their lives and their relationships. And when there is a disclosure, you want to be prepared to provide what we call a warm handoff or a warm referral to a local domestic or sexual violence partner agency or national hotlines. So again, even if the individual doesn't tell you anything, they're walking out the door with resources. And when they do disclose, you're helping them to connect with people who can really help. As primary care providers, we are jacks of many trades. We have lots of areas to address, and we're not experts in all of them. And yet we have these organizations at the state and local level that are experts, that do have resources, who can help, and we can help to make that connection. And you can see at the bottom here how to obtain. There are safety cards for many different populations, many different settings, and with different focuses. For example, physical health, sexual and reproductive health, behavioral health, ACEs and children and family impacts. So you can find these all at the links, and they're also on the resource page, as well as more information about cues and a very nice infographic that walks you through the steps. Can I see the next slide, please? So universal education really provides an opportunity for clients themselves to make that connection between violence, health problems, and risky behaviors. And this is something that's really important for those who have never experienced IPV or human trafficking, to alert them to both reinforce signs of healthy relationships and signs that things may not be going in a positive direction. Those who are currently experiencing, regardless of whether they want to share that information with you, as well as those who have a history of IPV or human trafficking and have maybe extracted themselves from that situation and need to really be aware of things to monitor and think about in their own health and lifestyle and well-being. So it really gives us an opportunity to connect. If the health center is using a screening tool as part of their required intake, that's fine, that's great, but we strongly recommend that first the provider or the individual engaging with the client do some universal education, make a connection before they dive into those specific questions that target abuse. Next slide, please. So there is developing evidence that supports the use of cues. And what we've heard from survivors, and there just was a new article published in September that again reinforces this. This was looking at individuals using the public health services in San Francisco. What we consistently hear from survivors is that they want autonomy, they want empathy, and they want compassion. They don't want direction. They don't want to be scolded. They don't want to be told what to do, what they should do. They don't want to be questioned about why they're in a relationship that may be damaging. There are definitely limitations to screening without universal education, particularly low disclosure rates, and the traumatic impact of screening as well. Confidentiality is absolutely essential. Individuals consistently communicate that they have serious concerns about their privacy. And these are very significant reasons that individuals do not disclose anything about what's going on in their relationships, is again, fear of what might happen next or who might find out. And we know that when you have universal education and empowerment messages and those connections to resources and partners who can help the individuals, we have better outcomes. So a trauma-informed comprehensive approach is what we really advocate for. And we know that as we do this work, and I can speak from personal experience, as you get used to using the cards, talking with clients, listening to clients, meeting them with an open mind and an open heart, you gain confidence and awareness and can really do this work in a more effective way. Next slide, please. So not only can you do good things for your clients, but you can also generate some amount for the visit, and certainly, and very importantly, record using ICD-10 code that you have either engaged in a conversation about this, that you have confirmed abuse, or that you have provided services related to abuse or maltreatment. And again, these codes are really important for national data collection as well, so that we can get a handle on what percentage and numbers of the clients that we're serving are experiencing these issues. Next slide, please. So Futures has developed some wonderful protocols and tools that help health centers to implement these changes in their practice and implement cues and universal education. So you can see there's a model protocol that's available in both English and Spanish. And there's also a quality assessment and improvement tool which you can use to benchmark your quality improvement efforts, so you can really track your progress and improve your services.
And one note about, oh, sorry, Erica, just to jump in, one note about
Please.
the protocol and looking at the participants on today's office hours. Francis Gonzalez is on from the Puerto Rico Primary Care Association. And the Puerto Rico Primary Care Association was really instrumental in helping us adapt the protocol into Spanish, along with Esperanza United that works with Latinx programs, domestic violence programs all across the country. So just know that some of your peers here are really experts in doing this work, in addition to Tiffany Conroy, who was a leader for Project Catalyst and is part of the Iowa PCA. So don't hesitate to connect with your colleagues, including Alice Weingartner, who is here from the Community Care Network of Kansas that just did an annual meeting where they were able to lift up the importance of IPV with different speakers, including a speaker from the State Coalition on Domestic Violence. So just to say you have a lot of expertise just among your PCA peers as well, and credit to Puerto Rico for helping us adapt this and make it meaningful in both English and in Spanish. So one of the things that we were able to develop early on in this work with HRSA and with FIPSA is an online toolkit that really walks folks through the action steps of getting involved in this work and partnering up. This was developed by 10 health centers partnering meaningfully with 10 local domestic violence programs. We encourage them to let us know what are the most essential tools and resources, also taking the tools that they developed and housing them on this toolkit and really lifting up the promising practices. So there you'll find the tabs at the top correspond to the actions. And you can find a lot of information on cues that Erica was talking about, as well as different scripts and privacy pointers and other technology privacy pointers. So check that out. And definitely, this is a key resource for your health centers as they're either initiating partnerships with local programs or even expanding on those partnerships. So check that out. And next slide, please. Just want to thank you. Erica and I really want to thank you for your time today. And don't hesitate to reach out to either one of us and check out our website, which you can see the URL on the bottom of this slide. And we'll pass it over and we'll be available for questions.
We have 2 more slides and then we will get to your questions. So please, if you have any questions, please place them in the chat and ask our wonderful colleagues and partners to talk about, to answer those as well. So these next 2 slides are from the CDC, and these are additional federal resources that we have. So CDC has a division of violence prevention, and in 2009, they actually launched the Veto Violence website. And it's their public-facing online resource for violence prevention, education, and training, and has free online trainings, step-by-step guides, resources, and technical assistance that incorporate science principles. Veto Violence currently has 22 trainings, tools, and resources, and they range from the prevention fundamentals to tailored trainings for specific professions on ACEs to implementation guidance to help organizations actually build violence prevention initiatives. So you see there's the QR code, there's also the link there. So this will be in the included in the slides that we will be able to share with everyone. Next slide. And we have additional resources also are about in areas of dating matters, training for educators, preventing adverse childhood experiences trainings, principles of prevention and violence prevention in practice. So they have these areas, and these really get into some different areas that specifically target these areas. So please look those up. And we are so excited to be able to share these as well. And then next slide. All right. So we are going to transition to having our speakers on the screen, and just wanted to thank everyone for participating and providing this great information. So thank you so much. So I'm looking in our chat, and there's a question that says, I know scope of practice varies by state, but do you have recommendations for team-based care in clinics? For example, do you recommend RNs, social workers, APCs, or physicians lead the conversation? And that may be for Erica or Anna.
Yeah, so I can start by addressing that. You know, as every team functions differently and patient flow is different in every clinic setting. So what you definitely want is someone who is trained in compassionate and empathic listening, understands the essentials of confidentiality, and can really engage in universal education. So when we do training, we train the entire team because every clinic has a different designated individual. I think it's a great thing, no matter who starts the conversation, that when you're in the room with the provider, that the provider picks up that conversation, just to kind of echo the importance, reinforce the card, ask, did you get the card when you met with whoever you met with before? I don't think it's really attached to any particular training or background, you know, professional training or background. I really think it's most essentially about being trained on how to do this kind of intervention or interaction. It often falls to a nurse's aide or nursing assistant or a health worker who's doing intake, because that's the way clinic flow goes. So if that's the way it goes, that's great, as long as they're well trained and that it's reinforced by the provider in the visit.
And can you share the title, and I believe this was Erica when you were speaking, the title of the article discussing the impact of the cues approach with individuals? And
yeah, I'm sorry, I'm looking, I was madly going through my phone. If I don't find it, you can certainly, I'm going to try and find it before we're done, but if I don't, you can certainly just email me and I'll send you the reference link. It was just published in September. So it should be kind of up on the list of emails. Thanks.
okay, here we have. What tools, resources, trainings are available for school-based health centers serving adolescents? That's a great question.
That's a great question. And we've had the privilege of partnering with the National School-Based Health Alliance for many years on both learning collaboratives, webinars, conference presentations, and tools. And I'm going to put in the chat a link to those recordings, which are always available. And also I'll put in a link some of our upcoming free educational programs that we're sponsoring, including a learning collaborative on emergency preparedness, a webinar on oral health responses to IPV, and another webinar on workforce support and really how we think about staff and employees and increasing their capacity to do this work, recognizing their own experiences with violence and also how to support them in supporting their patients. So I'll put those links right now in the chat for folks.
Eva Rose. Eva, are you able to take yourself off mute?
I think so. Can you hear me?
Yes.
Excellent. Good afternoon, and thank you for a wonderful office hour. I wonder if you could say a little bit more about the role of screening in this work. We want to, I feel, support health centers in working smarter, not harder. the CDC victimization assessment instruments were shared with us in the chat, so I'm looking at those briefly, but I'm also mindful of some of the information that Erica shared about how screening does not increase disclosure rates. So I wanted to hear from maybe you or maybe other health and other PCAs who were part of the former Catalyst, like how they struck the balance between screening and assessment, but making sure that they provided an environment where individuals feel safe to disclose.
Maybe I can start and then turn it over to Erica to add. You know, one thing we know from the CDC's survey, the NISVIS, National Intimate Partner Violence and Sexual Violence Survey that they administer, is that the lifetime prevalence rates of intimate partner violence for women is that 1 in 2 women will experience IPV in her lifetime, 2 in 5 men will experience IPV in their lifetime. And the rates are similar for LGBTQ folks as well. So when we know that there's a huge prevalence, and then when you look at screening rates for most any health system, you're going to find those rates usually hover lower than 1% of patients are actually disclosing that this is going on for them, so that we know we're losing a huge group of people who have experienced IPV. And we find a lot of challenges with people's comfort level in disclosing that this is going on for them, either that it's present or that it happened in the past, which we know can still impact their health. And so especially for women with children, they can be really concerned about disclosing that DV is going on, with the risk of child protective services and things like that. So, and others that are just uncomfortable with the idea that they can share that information, and then it gets into a database, and then who has access to that? And then what's coming home in terms of explanation of benefits and things like that. So there's a lot of really good concerns that people have as to why they don't want to disclose. And when we look at the disclosure numbers, they're just so low that we know we're missing most of the folks, both in terms of supportive resources, but also just information about healthy relationships and ones that aren't. So that's what I would say just in terms of the data and the rates. But Erica, go ahead if you want to expand on that.
So I mean, just in terms of going back to I think part of the question was, you know, how does this fit with screening? Is that correct? I'm going to, sorry, I got a little distracted finding, and the link is up now. So I am going to just quickly address how this interacts with screening. So again, many of us use electronic health records and have a workflow that requires different screening interactions. And one of those screening interactions may be screening for domestic violence or intimate partner violence. This is often done at the very beginning of the visit. It can be done in very insensitive ways. It's often framed. I just was at a primary care visit 2 weeks ago where and this is one of the things we always say in training, and then it happened to me. I was like, wow. The individual who was doing my intake said, "I'm sorry to have to ask you this, but we're required to. Do you feel safe in your home?" Now, that does not really encourage me to say anything. So what I said was, wow, that's not a very good way of asking me that question. But most people would just kind of put up and shut up and wait till this part was over. So screening in front of other people, as Anna identified particularly, this happens a lot with children because there's nowhere for the children to be during the visit. Screening in front of an abusive partner, screening without privacy, without sound or visual privacy. Screening with negative statements, "This isn't happening to you, is it?" All encourage a response of non-disclosure. So I hope between the two of us, we addressed your question.
And I just added to the chat a note that we've worked with 2 EHR companies, Ochin, their Ochin Epic tool, and also eClinicalWorks. So we've developed some smart tools with them to make this a little easier for your systems. Those are, for Ochin's Epic, you can also watch a training and get some background information before you put the smart tool in place. So just know that those are 2 additional resources, and we're going to be rolling out the eClinicalWorks in the next couple months, and Ocean Epic is already available to all of the users. So those are great tools as well.
So we have about 3.5 minutes, maybe 3 minutes left. And quickly, I'm going to start with this question. Can PCAs partner with other local domestic violence organizations to provide on-demand virtual training to health centers as an activity? I believe Bryant may have already answered this in the chat, but I didn't know if there was anything else. I believe
the on-demand part, I think, is the other question I have. The virtual part, this seems to be kind of it seems to be hands-on, the training. And so I'm wondering about an on-demand virtual option for getting just some base level IPV training as a start.
Again, we trust that the PCAs are able to do their assessment to see what is needed in the best way it can be offered. We did not want to narrow the focus by providing anything specific. So we wanted to leave it up to the experts in order to again, figure out what is needed and how it's needed. I think we've learned during COVID that we have to be flexible and being able to pivot just to meet the needs of our health centers.
Yeah, and I just want to, just remind, as Brian said, we didn't want to paint anyone into a corner, but just to, also, communicate your particular thoughts, any issues to your spot, so so you guys can kind of talk and work through it. There are certain situations that will warrant, additional flexibility or things of that nature. So again, to keep the lines of communication open.
any advice on how to balance our clinicians' obligations as mandatory reporters with knowing not always best for the patient? I'm just repeating.
Yeah, so I'm not sure which state that question came from, but not all states have mandatory reporting requirements around intimate partner violence. Of course, if it's an adolescent, that's unique. There are reporting requirements for adolescents, but for adults, very few states have reporting requirements. And I'm going to put into the chat a tool that outlines all of the different laws for states, territories, and tribes. And you'll see that most have requirements around gunshot wounds, burns to the body, and knife lacerations, but very few actually have requirements generally just around IPV. So let me share that with you. But that is a common concern that comes up, which is why we developed a tool that really clarifies some of those requirements.
I would just add that the most essential piece is being transparent about reporting requirements before the fact, not after the fact. So that's why we advocate, first seeing the client alone and next clarifying the limits of confidentiality so that people can make, this is part of empowerment, is the ability to make an informed choice. And so that gives the individual the opportunity to make an informed choice, know the resources, and they may choose to disclose in a non-healthcare setting because they feel safer. So that linkage again with the advocacy partners is really essential to give them an alternative route.
We are at the top of the hour and really appreciate everyone's time for participating today, and also to our partners with the Bureau of Primary Healthcare, Sade, Sean, and Brian, and Anna and Erica of Health Partners on Intimate Partner Violence and Exploitation, Futures Without Violence. So many great resources were shared today. We really appreciate this. And we just appreciate everyone participating and wish you all the best in the next year, especially in this first year of this activity, and then the next 2 years. So appreciate the partnership and working together on this. So thank you all. It was a
Thank you.
Do this together. So thank you. And then again, we have, just to remind everyone, we have a short survey to see how we did. It's very important that we understand that and learn from it. So We want to know what we did right and what we can improve on. So the link is in the chat. We will also be sending this out tomorrow as well. So thank you all. Have a great rest of your day and week. And thank you again.
All right. Thank you. Take care, everyone.